Hey, everybody. Welcome to another episode of the OIG Roundtable. Got a great topic to talk about. We're talking about TCD, transcranial Dopplers. I've got my two partners in crime, Wade McFall, assistant special agent in charge, retired from the LA field office and now manager on our SI investigative team, and Matt Kachansky, the retired special agent in charge from OIG headquarters and the retired Northeast UPIC director. And now the director of our payment integrity team. And we're going to talk. So there was a press release that came out the other day regarding a $70 million fraud involving a sales manager or a sales rep out of New York who is intending to plead guilty to a $70 million fraud relative to kickbacks paid to providers for what appears to be the purchase of a transcranial Doppler or TCD machine. And that included apparently some sham documents and things of that sort. So first thing is the provider, the sales rep was in New York. The case that's showing that this guy, he's not a provider, is intending to plead guilty is out of Boston. We can't read the tea leaves, but we're all thinking that there was probably a key tam that was filed. Boston, for those that don't know, Boston is one of the most prolific districts in the country involving PTAMs, primarily in the pharmaceutical space, but they have since obviously branched out. And Relators Council tend to go to the districts where they're going to get the best bang for the buck because it's a money-driven case, key TAMs are. So this is interesting because of that. What's interesting about this press release specifically is that they're talking about how the defendant in this case is intending to plead guilty, hasn't already pled guilty. Normally in a press release, you either see a copy of the indictment, the information, the plea agreement. None of that was attached on this. I did not get a chance to go into Pacer and look to see what's there, but it is unique when you see an instance in which it indicates that a defendant is intending to plead guilty versus already pleaded guilty. My favorite thing was in reading the press release, the list of agencies. Matt and Wade are laughing because the list of agencies that participated in this case was unbelievable. I think there were more agencies, less agencies that didn't participate than there were that did. It was pretty unbelievable. But that being said, this is becoming it's an ongoing issue. The use of technology in healthcare is obviously an important factor in the proper care and treatment and diagnosis. It's part of access to care and getting quality care and all of that. But it's, we know it. Everybody in this industry knows that the companies that produce these devices should not be providing billing, coding, documentation, advice. It just shouldn't be there. The providers need to use this tool for their appropriate medical decision-making when patients present with a condition that requires the use of it. And for those of you that are auditing geeks, transcranial Doppler are in the 938 range. I think there's 5 codes or 6 codes, 938, and then 2 digits there. I think it starts 93888 and then goes on. And depending upon the study and the number of regions you're looking at, will get you different reimbursement rates. I worked on a TCD case a couple of years ago. It was a self-disclosure provider, bought a machine, got billing and coding advice, relied upon that billing and coding advice. All of a sudden, all the patients that he was doing that on started to mysteriously get the diagnoses that were the payable diagnoses for those codes. Everybody got it. Nobody had the problem. It became their primary diagnosis, even though they never had it before. Wound up being a couple of $1 million in an OIG self-disclosure. So you can get a pass on criminal cases in some instances. In this case, the provider was not criminally prosecuted, paid $2 million back and did their self-disclosure. But Matt, I want to start because when you were running the UPIC, when you were the program director at the UPIC, I know that Northeast UPIC embarked on a project to work on these cases. And I don't know if it's so much the challenge, but when you've got an instance in which the manufacturer is producing guidance, suggested guidance, and things of that sort, it's problematic. And we were just looking at a website for a particular manufacturer, and without disclosing the name of that manufacturer, they listed the CPT codes, they listed the descriptions, they listed the diagnoses. And Matt, What was the punchline at the end of their website?
The punchline at the end, and I'll get into the background of this whole scheme. It says it is clear that that by using this system, the medical practice not only gets valuable clinical information, basically screening information, not based on any type of diagnoses of a real reason for using this type of equipment. The medical practice will also benefit very quickly to receive a return on investment for improved profitability. So they just throw the profit incentive in there as well, into their ad on the internet, and it says, what is needed for this. It's just to build these codes, just this machine. It doesn't talk about what necessary diagnoses are there, or the condition of the patient, or the fact that these things need to be ordered individually by a physician that has examined the patient and said they're at risk of something. No. What we saw in the UPIC, and we might have
But wait, hold on,
actually,
Matt. So, but
yeah,
the key point is, regardless of anything, the manufacturer of this device is saying this is a cash cow.
this is
Like,
a
let's
cash
not
cow. You
sugarcoat
can
it.
build all 5 of these codes using this machine
Have at it.
and have at it.
Have
No,
at it.
you need nothing else but this.
That's it.
Yes, that's it.
And by the way, as the manufacturer of this device, we're not taking a position either way. We're just saying, hey, doc, we have this device. Here's your spread, right? This is essentially, to me, I think of this a lot as the functional equivalent of marketing the spread, which for those that don't know what marketing the spread is, it was very common when a lot of the physician administered medications started to come out. One of the, some of the drugs, like for rheumatoid arthritis and things of that sort, where the doctor pays one price for it and Medicare reimburses or insurance reimburses another. And if you were a provider who might not have had an interest in doing this, what the manufacturers were doing in the early days is they would come in and their sales pitch was, hey, doc, if you do this, you're buying this for $1, you're going to get reimbursed $2. It's going to cost you X number of dollars to create the room that you need to do these infusions. And in 6 months, this is where you're going to be. And then it becomes a profit center. It's the same type of scenario. So, yeah, so go ahead. I didn't mean to interrupt.
Yeah, I mean, this scheme, and it might have been that one of the UPIC cases we referred to the OIG in Massachusetts might have been this one that they got the plea on. But we had a large scale project on this throughout the Northeast. And what we were finding was it evolved over time, but it started with ophthalmologists being marketed these types of machines and then buying them and then billing for these 4 or 5 TCD procedure codes as part of their annual eye exams, with these patients. So we started looking into this as just, why is an ophthalmologist billing for neurological tests? And sure enough, they were being marketed by these machine manufacturer distributors and giving that type of literature of, pay for this. This is what you can possibly get out of it, and showing them that spread. And they started billing for it, and there was never any medical need for these tests. If you look at the CMS website on the criteria for billing these types of tests, they can't be used for screening. These have to be used as part of a person's care that is at risk of stroke, or maybe even going through a stroke.
Right.
And it's not an annual screening. So we were getting reimbursements for these things. We turned a lot of these things over to the OIG, who found, found further evidence and kept going with these things. We also saw that the scheme evolved, because they started to catch on that we were just looking at the ophthalmologist billing and seeing that they were out of the ordinary. So now, instead of selling them the machine, they would sell them the rights to use their technicians to come in and do the tests, and we'll rent space from you we see your patients that you refer to us. And then it's the diagnostic company, the mobile diagnostic company that bills for it. Sham rental agreements, all based on the revenue, generated and the number of patients referred. And then they started screwing around with the combination of codes, trying to just throw us off the track. But it was probably dozens of cases we opened up on different providers. And it was a heck of a project. And
well, and the interesting thing with the use of the technicians from the company is, what is also pretty common is when, for example, in the lab space, when a doctor's got a lot of blood work that they're doing, and the lab hires the employee of the doctor's office, right? And so they're not, when you're working in a doctor's office for the lab, you can't be doing ancillary work on behalf of the doctor's office. You can't be answering the phones, you can't be a medical assistant for the doctor when you're being paid by the lab to be the lab tech. And, I know that the other pretty common scheme, which is similar, is the person becomes on paper an employee of the ancillary service, which is an indirect kickback, right? Because now the provider, let's say you're paying your salary for your technician, your medical assistant, let's say they're making $50,000 for argument's sake. Now that $50,000 goes on to the payroll of the company, the ancillary service, and now that you basically get a $50,000 kickback, right? So you mask that, in that vein. But it does create, like, it's a subculture, because these become very challenging cases to do. And wait, the thing that Matt brought up, which is, like, the policies become an important part of this. But coupled with that is, from the investigative perspective, you've got to talk to the people that you work with in your department. You've got to talk to your clinical reviewers, your documentation reviewers, because you really need to know, what are the documents that I should be asking for? What are the documents I am expecting to get? But this is where Dr. Google can come into play. And I don't mean Dr. Google from the clinical, but, doing this research, these are all kind of that background, right? It's not an evolving type of scheme, but it's something that's off the beaten path. You got to kind of know what you're looking for, but you also need to know, when you're talking to people, you got to know what you're talking about.
Yeah, and this is another example of, most of the agents don't have a clinical background, so we can't be right. From the get-go, we're not subject matter experts on, like, probably nobody was a subject matter expert on transcranial Dopplers before we started looking at these cases. So it comes back to that, it's not what it's where to go get the answer. So like you said, you talk to the auditors, have discussions with them, you do conduct policy review, you do a lot of Googling, just kind of any research you can get. You probably want to look at when, as you mentioned earlier, when the machine was obtained, so you can see when there's a trend of different billing patterns based on, when they got this new machine. Look at the marketing information from the manufacturer, but also CMS had a lot of subject matter experts, medical directors from different departments within CMS. So another good source that, you probably don't want to just reach out to your local physician of the same practice, because they all know each other and they'll talk. But I think if you reach out, we used to do this quite often, reach out to CMS, and they have specialists who, are familiar with these procedures and this kind of subset of practice. So reach out to CMS and talk to somebody who's more familiar with this. And then before you know it, if you've worked this case, you guys both have, and you're probably as much subject matter experts on this as anybody in the OIG. I've personally never worked a transcranial Doppler case, so not me. But once you work the case, you spend a couple years on it, and talking to the different people that you can get the information from, you'll pretty much become a subject matter expert. And it's important to kind of do all that research and get that knowledge prior to, for example, your initial document requests. If you just send out generate a subpoena and you don't really know what's going on, you don't have the big picture, you're going to miss a lot of documents that are required and that would help prove the case. So you want to do all this information gathering and research and interviews with various people, auditors and SMEs prior to sending out those document requests so you can hit all the main spots.
And in the non-government space, in the SIU space, this is where you want to talk to the medical directors within your plan. This is where that cross functionality comes in. I hate to have that corporate speak, but that's really an example of it, where you've got to have that cross functionality, being able to function with different departments, understanding what the TCD is supposed to do, understanding when it's supposed to occur. I think from a data perspective, Wade, talk a little bit. I think from a data perspective, if the diagnosis required for a TCD miraculously starts appearing in the data, and it's commensurate with when the machine was purchased or the patient, I mean, those are going to be some of those data points, right, to look at. And that's where I think having some of those documents or understanding when did the machine come,
right,
things of that sort. There's other pieces of that puzzle, right? So data will come into play in some of this.
Yeah, it's about the outliers. If they never built this before, that's definitely an outlier. If they started doing it about the same time as they obtained the machine, outliers, trends. It doesn't necessarily mean that it's 100% fraud, but that's a reason to look into it, and find out why they're all of a sudden billing this. Maybe it's a new skill that the provider got. It's probably more likely just that they got the machine. But as long as they hit all the other, medical necessity requirements and prior, visits with the patient, a lot of things that could make it not seem like fraud. But you definitely can't ignore the fact that, they purchased the machine on, January of whatever year, and then all of a sudden those codes start showing up as a graphic outlier.
Right. And the thing to keep in mind is in this particular case, it's a kickback case. And so the issues involving medical necessity, did the patient need it, did they not need it, really don't come into play, right? Kickbacks are illegal in the federal healthcare space for reasons other than medical necessity, that have to do with things like increasing the cost to the government and things of that sort, clouding the medical decision making, not necessarily taking the place of it, but that becomes a factor. And while at the end of the day, from an SIU investigative perspective, you may be able to uncover a kickback arrangement, that's a little bit more of a challenge versus understanding this. I mean, if we were in the SIU space, we would be looking at whether or not these records documented reflect this issue that the patient has and things of that sort. But one of the things that becomes interesting in doing a case like this is, was the patient a long-standing patient of the provider? Had they never had the diagnosis that's required for these 5 studies? Are there other studies, and this is where we have to talk, I think, to your medical directors, is were there other studies that were done for the patient in their billing history that don't require them to have the TCD? Meaning, is there another similar test that was done, or is this a pile-on? It's a little bit like, I always like to use the discussion in cardiology. If a patient is being diagnosed with a heart murmur, there's really one test that the patient needs typically, and that's an ultrasound. But if you were to look at the diagnosis of a heart murmur and you were to look at all of the different tests out there, there are probably a slew of things in which the diagnosis of heart murmur would fit. And so there's a line between defensive medicine and fraud, waste, and abuse. And so, there's kind of this argument. It's sort of like in the genetic testing space. If you're someone who's been on a statin drug for 20 years and a doctor orders the genetic test to determine whether or not your body is going to metabolize that statin, and you've been on it for 20 years, that genetic test is useless. You've been on it for 20 years. It's been working. It's doing what it's supposed to do. You're not really providing any valuable medical information for that. So I think that's where when we're looking at this in that space. And that's why looking at that billing data and looking for that outlier. And I think, Wade, you hit it. Like, did the provider not bill for this? Now all of a sudden they're billing for it. Remember, we've talked about this a lot. I think it's not even a matter of that outliers are always fraud, waste, and abuse. There's lots of reasons why providers are outliers that are legitimate, but it's obviously something that has to be scrutinized. That's why we say to the provider community, know your data, right? If you're an outlier, it doesn't mean a bad thing. An outlier is an outlier. It could be for a number of reasons. It's just understanding what makes you an outlier. But Matt, I want to go kind of to bring this back to full circle. So in this case, it was a $70 million fraud. There's $20-30 million that's going to have to be paid back in restitution. Obviously, in this case, went on from 15 to 20. My guess is that there was a key tam that was filed, and it's taken them 4 or 5 years to get to this point. And who knows what else is going to come of it. But for me, the biggest challenge in these cases, forgetting the kickback piece of this, is that you really have to understand what the policy is. And these policies, I just did a quick look. A lot of these TCD policies have evolved over the years. There have been policies that have been, I just looked at the CMS policy. It's been superseded at least one time. And so the thing I think, right, for investigators is you've got to be able to equate the policy in effect at the time. And so understanding your data and understanding your time period, your start and your end. But then the biggest piece is that research and aligning policy to the data.
Absolutely correct. Yeah, without doing that, you would create so many false positives that are fodder for a defense attorney at trial or for any type of civil briefs that might be filed. You have to make sure that the policies you are using, and make sure that if it's a Medicare case, you're using the Medicare policies. If it's a Medicaid case, you're using the proper state that were in effect at the proper time to make sure that your findings are going to be supportable. And sometimes it's not easy. Sometimes those regulations and policies change over time. With Medicare, as we've talked about before, they could be one policy in New Jersey and one policy in New York. For a provider that works in both states, they could be working under two different policies because of the different LCDs that are in place. So you have to be very, very careful about making sure you're applying the correct policy to the behavior at the time. One thing I will say that we haven't talked about is in our investigations at the UPIC, we talked a lot to the patients. They never got any results from these tests. Yeah. And one of the things that's a requirement of any test is that it's used as toward the future care of the patient. Sometimes the results weren't even in the medical records. So there's another thing that you should be looking for in the investigation.
Right. Well, and I'll just bring up, on the screen here. So I just pulled this off of the web, and it's showing the magnitude of reimbursement based on the CPT code vary by state and region. It's clear though that by using, this is the manufacturer's name of it, which I'm going to get rid of here, routinely, the medical practice not only gets valuable clinical information for the patient, but can also very quickly receive a return on investment for improved profitability. And so, this particular manufacturer is clearly demonstrating that by using their device, it's going to give you a financial windfall.
But they do give a warning. They say, what is required for reimbursement of TCD studies? So it sounds like they're going to get into what the clinical requirements are. The main requirement is to have a TCD machine with the option of a robotic probe to speed up the process.
Versus a flashlight that you're going to put on the person in the back of their head. Hope you can see through them.
They're just incentivizing the providers, clouding that medical judgment by saying, there's quick bucks involved in this as well.
Right. I mean, look, at the end of the day, these companies are in business to make money. They make devices that help with the care, diagnosis, and treatment of patients. It's an important part of the healthcare continuum and a modality that's obviously viable. CMS covers TCD machines. It has got obviously medical efficacy to it, but you have to take some of this with a grain of salt and do your independent research, because at the end of the day, if you do this wrong, you can't point the finger at the manufacturer. The manufacturer is going to say, these are the TCD codes. Do your own research and identify whether or not this code fits with what you need to do for your patient and how to document it. So, it is what it is in this industry, but you should never take what the manufacturer says as absolute guidance. You've got to make sure that you've got your ducks in a row on this. So it's going to be interesting to see, where this particular case goes, because I don't think I've ever really seen, or not that I can even recall, an instance in which a press release has come out where they talk about the predictiveness of a plea. Normally, the press releases come out after a plea has been entered, and information is filed, a plea agreement is filed, an indictment and a plea agreement. You really don't see these instances normally of providers who are predictively going to be, or individuals predictively going to be pleading guilty. But the fact that it's a 2015 to 2020 case, salesperson or whoever this person is from the company is located in New York. It's a Boston case. So, I think the tea leaves tell us, the three of us, that this is probably a key tam, or at least something with a cooperating witness of some sort. So interesting. And, again, I said I did a case like this a couple of years ago. Matt, you were at the UPIC now, several years ago. You were working on this. Whether it is a TCD machine, whether it's an ultrasound and a provider using an ancillary service to come in, these schemes, paying rent, masking your agreement with rent, none of this changes, right? I always want to go back to retro fraud. It's the circus doesn't change. It's just the clowns in the circus that changes. So, this is why looking at press releases and looking at other enforcement actions around the country are predictors of what is going to, of what's out there or what's to come. So it'll be interesting to see how many more providers and people are implicated in this.
Yeah, there was just another one. I don't know if it's related or not, but in Florida, same scheme.
Yeah. I remember that was a couple weeks ago.
Yep.
So this is, I think there's probably a push for some of this corporate malfeasance, but I think from, going back to the grassroots of these investigations, again, if you're looking at it strictly from a kickback perspective in the SIU space, maybe a little bit of a challenge, but it doesn't mean that you can't uncover some of these things. You can certainly start making requests. I know we did a couple weeks ago, we talked about ADRs, additional document requests. You can still make an ADR for supporting documentation that supports that you even have the machine and when you got it, and is it in a back room with dust? And that's where, in some cases, I guess there's an argument to be made for on-sites in the SIU space. Nothing better when you're an investigator to show up at a provider's office and they have a machine and the machine is covered in 3 inches of dust, or it's in a room, it doesn't even work, or it's in a closet or something like that. So, there's something to be said about doing on-sites in that regard. At the minimum, doing an on-site gets eyes on for things like that. You would never necessarily know that a machine is sitting in a back room or a closet covered in dust or broken or what have you, if you don't necessarily, get eyes on yourself. So interesting case. Transcranial Dopplers. I think it's not new technology, but we've seen in the past couple weeks, a couple of cases on it. So I think it's probably something that we should be looking at from a data perspective. We should be checking out those cases and see what's out there. So good insight as always, guys. It's always good to see you. And again, thanks to everybody who joins us every week. We've got some great LinkedIn Lives coming up in the next few months. As always, the podcast every Friday delivered right to your inbox on LinkedIn on Thursdays, to your inbox on Fridays. Join us every week for the conversation. And until next week, we'll see you all on the next OIG Roundtable. Take care, everybody.
Thank you.
Thank you all.